Hello, everybody that's joining us. We might just give a moment or two. The numbers, the attendee number. I'm live watching the attendee number list, and it's going up and up and up and up and up, which is fantastic to see. For those of you who have not met me, my name is Chris Tremonti. I'm an addiction specialist and clinical pharmacologist over at St Vincent's Hospital in Sydney. And I will be chairing the DARIA sessions for 2023. You might remember me from some DARIA presentations from 2022. For those of you, so DARIA has had a bit of a revamp in the off season. Think of it as like your favorite footy team. It's come back with some new strategies and techniques, but DARIA is of course the Drug and Alcohol Research Innovation Active Learning Network. And so just for those of you who've not been to any of these sessions before, this is a chance to showcase research and results and clinical innovation around drugs of dependence, emerging drugs, and other relevant issues, and try and bring together disciplines and cultivate a space for critical thinking and dialogue, and try and provide an opportunity to provide high-level clinical care. It's not we don't tend to present sessions that are purely, the ins and outs of alcohol withdrawal or the ins and outs of any particular drug and alcohol issue. We are trying to keep it research focused. Of course, when one presents research, there will be a bit of clinical background, and I'm of course here to sort of provide a little bit of clinical insight as well, but we will be mostly research focused, as you can tell probably by the first presentees. We'll also be this year trialing having a more panel style setup. So rather than just having one person talking, we'll have a few people on a panel, and that way that there'll be a bit more sort of interactive discussion. And of course, you can put questions in the chat, and we can try and get to those questions as possible. If you have any ideas around things that, or you've got some research you yourself would like to present, we're of course open to suggestions. We will have the email in the chat as well, but it is ncred@unsw.edu.au. So do feel free to hit us up with suggestions, feedback, ideas, whatever else. Furthermore, the sessions for this year will be monthly. Whilst there's a lot happening in the drug and alcohol space, it would be incredibly challenging to fill a weekly spot with a new and innovative bit of research. It's hard enough to get research out there as it is. And of course, so these will be monthly sessions at this stage. And we've got a reasonably full calendar at the moment, but there's still a couple of gaps there, as I say, for people later in the year if people have ideas. So before, without any further ado, I'd like to introduce today's speakers, Alana Story and Dr. Krista Siefried. For those of you who don't know the people presenting today, Alana is the Senior Clinician for the Alcohol and Drug Contact Centre at St Vincent's Hospital, and she's a trained clinical counsellor, has worked in different drug and alcohol settings for the last 6 years, starting in rehab and community roles, and then transitioning to St Vincent's Hospital, working in both STP and S-Check services as part of the stimulant services team prior to her current role. Krista is an experienced clinician researcher with broad experience in academic, investigator-initiated and industry-sponsored research, including multi-centered randomized clinical trials, cohort studies, and case control studies. Krista's background as a registered nurse led her to clinical research, where she's worked at every level of clinical research in various therapeutic areas, including cardiology and cardiothoracic surgery, neurology, HIV medicine, and addiction medicine. Krista is an experienced clinician with broad experience in academic investigative sponsored, including, already said that. I think I've got the same bit of information on Krista there twice, but she's so good, it's worth hearing twice. So without any further ado, I'll let them talk today about strengthening first-line telehealth for people who use methamphetamine and emerging drugs. Thanks very much, guys.
Thanks, Chris. It's great to be back for the Daria session. And for today's session, Alana and I are really happy for anyone to join us in the panel discussion at the end of the presentation. So if you are happy to be unblinded or unmuted, you can go on camera, not on camera, be on mute, not on mute with any conversation at the end. So we can facilitate that. Just pop it in the comments and we can add you to our panel. In the meantime, we'd like to start with presenting some research that we've recently done nationally in Australia in the Alcohol and Drug Information Services. So first, I'd like to start just by acknowledging country. So I acknowledge that the research that I'm presenting today was developed on Gadigal and Bidjigal lands and conducted on First Nations lands across Australia. I pay respect to elders past and present of all of Australia's First Nations and Aboriginal and Torres Strait Islander people who are joining us on this call today. I recognize the strength and resilience of those people and those who maintain a continuing connection to the lands and waters in the region, a right and responsibility that was never ceded. Just a couple of disclosures for the research that I'm about to present in terms of setting up the discussion following. This research was funded by the National Centre for Clinical Research on Emerging Drugs, and the results reported here are currently under peer review at an academic journal. And that study is called Methamphetamine and Emerging Drugs of Concern, a Training Needs Analysis of Australian Alcohol and Other Drug Helplines. And the authors are listed there. Hopefully, some of them are joining us today and able to join the panel discussion following. So a little bit of background to Australia's alcohol and other drug helplines. There are several accessed nationally through a single line or accessed locally. Between them, they cover all of the states and territories and provide 24-hour access to counseling services. They're frontline and they're often the first line of contact for people who use drugs, their families and friends, employers of people who consume drugs, and others in the community. So these services may reach people in the community who otherwise find access to be limited. Some easy examples to see where that could be include rural people or regionally located people, people who face stigma or who belong to marginalized communities and don't feel confident accessing mainline or mainstream treatment services. This can be a segue into next steps, or it can be some of the steps in itself, which I'll touch on here. So between those helplines, they field over 100,000 calls annually. So I think that we really underestimate the value of this frontline service. And I think that we really need to pay attention to the fact that this is a really important service, a skilled service that provides anything from education and information to people who use drugs or concerned others. They can provide referrals, they can do crisis counseling, support around illicit or other drug use, including where to access things like harm minimization and harm reduction, free access for people who are worried. So again, it's free, it's available when you need it. They do brief intervention. It is a really holistic service that really meets needs of callers, and those callers can be quite diverse, as we'll find out in a moment. So the Australian AOD telephone services are actually run through states. However, some states like Victoria provide the support, are contracted to provide the support to other states like the Northern Territory or Tasmania. They can be accessed via that national hotline that I mentioned earlier. So there is national coverage for everyone who calls in. They will get someone in the area that they are referred out to, which means that you could get information relevant to where you are, depending on your state or territory. There is limited evidence, but there have been studies that demonstrate that AOD helplines support reduction of substance use and increased treatment uptake. And telephone counselors are required to keep up with rapidly changing drug use trends and new treatment evidence. In addition, the variability between services means that staff training needs are diverse nationally. So a bit of background about methamphetamines and emerging drugs. Methamphetamine dependence and regular use in Australia has increased in the past decade, and Australia represents the highest use of methamphetamines globally. Evidence-based treatments for methamphetamine use disorder are still emerging, and other emerging drugs of concern include new psychoactive substances, which are appearing on the market, including novel drug classes that might be potentially harmful, new formulations of older drug classes for which problems related to their use are emerging. For example, fentanyls, an old drug with new problematic use in some contexts, as well as novel synthetics like synthetic cannabinoids, novel benzodiazepines, etc. A 2019 study of AOD clinicians, researchers, and people who use drugs and concerned others identified communication strategies regarding evidence-based treatments for methamphetamine use disorder as being a key clinical research priority. So that really set the stage for us to start looking at the alcohol and other drug helplines a little bit closer and seeing how we could respond to that emerging priority in this context. So training needs analyses are performed across healthcare and other sectors to support effective continued professional development. So continued professional development, or CPD, those opportunities are highly valued by organizations and by staff. They improve service delivery as well as contribute to staff retention. Conducting an analysis of training needs ensures demand-driven evidence dissemination and training needs that actually align with what your staff require at that time. The Hennessy-Hicks training needs analysis is a validated tool in healthcare settings that's from the World Health Organization, and that's what we used in this study. So what did we do? We did an adapted Hennessy-Hicks training analysis with an anonymous online cross-sectional survey distributed from October 2021 to April 22 to helpline staff nationally. That data that was collected included participant demographics and professional characteristics. And the questionnaire itself was based on that Hennessy-Hicks training needs analysis and clusters around 5 themes, including research and evaluation of evidence, communication and teamwork, clinical tasks, administration, management and supervision. And we also included some qualitative responses. So that included open-ended questions. And the way that we analyzed the data were by mean scores for each importance item and performance rating, self-rating, and that was calculated to figure out a mean difference between the perceived importance of the item and the perceived confidence with performing the item to create a deficit score, so where we found that most of the training needs were required. In the descriptive content analysis, we ensured that the training needs were comprehensively summarized. So the results, we received questionnaires back from 50 people of an estimated workforce of 110, and 47 of those completed the questionnaire, 29 in its entirety, and 18 in partially completed response sets. So partially completed responses were included if they contained responses to all of the Hennessy-Hicks training needs analysis items. So that left a sample of 37 of that 110 strong workforce. Of the entire sample, the median age was 49 years, and just over half, at 62%, were female. The sample included a diverse range of practitioners and professionals. These were predominantly self-identified as counselors amongst 68% of participants. And following that was nurses at 15%, social workers at 12%, and psychologists at 5%. The qualifications were predominantly bachelor preparation in just over half, whereas nearly 25% of the sample had master's degrees, and graduate degrees were reported amongst 14% of the sample. The length of time working in the sector was from 4 months to 42 years. So there's quite a diversity there. The interquartile range was 1 year to 20 years. So quite a span of experience across our AOD telephone services nationally. So what did we find when we did this study? We found that the results for training needs clustered predominantly around a few key themes, which we'll see in a moment. But essentially, the highest training needs scores were identified for providing information to clients and others on cathinones, promoting fentanyl testing as a health promotion activity, accessing and participating in training, so having that sort of time and support to access training, and communicating with culturally and linguistically diverse clients was another highly ranked training need, and providing information to clients and or families on novel psychoactive substances. So a lot of the new drugs in the market featured here, as well as communicating with different priority populations, so families, CALD patients, etc. So when asked to comment on particular emerging drugs on which participants would like further training, respondents listed a wide range of both established drugs and novel psychoactive substances. Most commonly cited were depressants, particularly GHB, stimulants, particularly cathinones, opioids, particularly fentanyl and its analogs, and methamphetamine. So we just presented this as a drug wheel. That's thanks to the ADF there. In the qualitative analysis, when asked if there were any subgroups of callers that respondents felt required clinical skills strengthening in their practice, they reported that families, friends, and concerned others were predominantly a challenging client group to talk to, that they felt that they could use more training. Participants felt that they were expected to fix a problem for the caller quite often, and highlighted a level of expectation to have exact knowledge about methamphetamine and emerging drugs in order to offer the absolute correct information to them. So some of the complexity was attributed to misinformation in the media influencing public perception. So callers were influenced by media narratives that didn't necessarily comport to actual facts. Particularly around substance use disorders and some prevailing very prejudicial views, which the service providers found difficult to manage in those calls. When asked if participants felt there were barriers to training or accessing resources in relation to methamphetamines and emerging drugs, respondents largely stated that there were none, or that they were not aware of barriers to accessibility or issues to training or resources. Well, some participants did name time constraints as a key theme. So others articulated a lack of awareness of practical or population-specific information relating to methamphetamine and emerging drugs, or to their treatment modalities and caller population groups that could be translated into AOD counseling calls. A number of participants did suggest a dedicated database, particularly around emerging drugs, would be a useful resource that they didn't feel they had. But if they had access to something that they knew was evidence-based and able to be quickly accessed whilst on a call, that this could be a solution to the problem, but it required a scale of attention to keep up to date and informed that they didn't feel that their services supported. So our study had some limitations. There's obviously a potential for non-responder bias, or indeed for responder bias. So that is, participants who completed the survey may have been more likely to be more interested or value continuing professional development. It may not be generalizable to the broader Australian workforce, but it does represent nearly half of the AOD telephone counselling workforce. And I also just want to pull on this thread for a moment just to suggest that this frontline and very first line service may indeed be a bit of a canary in the coal mine when it comes to emerging drugs and issues in the community, particularly with prevalent concerns or emerging harms. And I really think that this is sometimes overlooked more broadly across the sector. This is often the first line of inquiry by patients or their families. This is often the only information source that some patients will receive. And so those clients really can be telling in terms of future themes within the rest of the sector and the ripple out effect that's coming. So I think that this is really a population of our service provision that we should be thinking about how best to really leverage the information that they receive and the intel that they would have in terms of service provision more broadly. Another limitation would be that the Hennessy Hicks was modified to fit this workforce and subject matter. That's pretty common in these kind of surveys, and the impacts of those kind of modifications can't be known. Our study also had strengths. To our knowledge, it's the first study specifically addressing knowledge gaps and upskilling opportunities across the national AOD workforce. Of helpline workforce. And we did identify some strategies to mitigate barriers, suggest content and skill areas, and various ways that this workforce would like to access new information. And just in closing, before we go to discussion, the training needs identified here did traverse direct knowledge gain through to more soft skill development. So for example, direct knowledge gain, we want to know what's new to the market, and we want to understand what we need to know about new drugs, for example, the novel psychoactive substances that we saw on that previous slide, right through to skills development. How do I better serve a population of culturally and linguistically diverse folks who are calling this line? So leaders can be aware of this in planning their education series and promoting other work done within the sector across a variety of modalities, which are available, which may help to address some of those gaps or skill development. So there are webinars, short video abstracts, and online training modules out there, and it may be bringing these to attention based on those needs, or certainly working in the way that this study did, whereby we can leverage the collaborations established in the process of this study's implementation in building clinical and academic alliances that deliver knowledge translation that's reflective of the priorities of the end user, the person who actually wants the training, that it's responsive to those needs and those current trends. In future, it would be really beneficial if we could have larger studies to map the AOD sector more broadly, to allow for more nuanced analyses around training needs by various professions or roles within the sector, within various contexts of delivery of care, etc. And just in closing, obviously I want to thank the study participants and the investigator team, and also just to point out a few related resources that are available by NCRED and some of our partners. So those QR codes will link you to our clinical guidance notes for methamphetamine. We have some of those for people who use methamphetamine, and we have some of those for primary care providers. There is a telephone counseling toolkit, which was developed in partnership with the ADISs and Insight Queensland, which is a great series of modules that can be adapted for anyone who's giving any kind of telehealth or online care or counseling. And then there is a video abstract of this research, Strengthening First-Line Telehealth, that has just been released. That's there as well. That could be useful for a variety of audiences. It's just a very short, brief video. And then I'm hoping to be able to share a publication on the NCRED website in short order. I would also like to note that the lead of this research was Florence Bascom, and she's currently running a hospital for MSF in South Sudan, so she's not available to join us today, but she worked very hard to implement this, and so I'd like to acknowledge that I'm presenting this really on her behalf. And now I think I'm going to ask Alana and Chris to unmute and video camera themselves, and we can hopefully start a discussion.
Thanks, Krista, and for that presentation. Feel free to, if people have got questions or comments or anything they want to add, to put that in the chat. And I think we've already had a couple of things come through. One thing I just want to ask about is just with some of these resources, sometimes things can go dead, as it were. And I don't know if you've got any experience with some of these telehealth resources and so forth, sort of suddenly being there one moment and not being there the next. Have you had any experiences of those things?
So I think, yeah, sorry, you go.
No,
Alana.
Krista, you go. Yeah.
So I was just going to say, I think that's one of the key things about these kind of clinical academic alliances in terms of developing this kind of research, because then we do have a motivation, but also a responsibility to now deliver on some of these results and start making sure that our translation activities accord with what we found. In terms of some of the things that are available online, I did notice that during COVID, it felt like there was quite an extensive uptick in resources. And sometimes it's hard to weed through what is the best resource and what is going to give me the best or the most bang for buck in a sense, what's going to be sort of the most skills in the least amount of time, what's going to really do that. And I'm not sure how to sort of collate those, but really interested if anyone has any ideas of how best to sort of organize that for our colleagues.
Alana, did you have anything else you wanted to add on that, or
I was actually going to echo what Krista said. I think certainly through COVID, it brought to light a lot more importance of telehealth and phone lines and creating broader accessibility. So definitely there's a lot more resources out there, but as you say, Chris, then they can kind of then take a back seat once things, I suppose, go back to face. But they're there, and it's, I suppose, taking the time to find and collate them all to have, I guess, one or two major points of reference for telephone and telehealth services.
we've got a few more questions coming in. Alana, was there anything else you wanted to add just in general about any of this, or you happy to jump to questions?
Yeah, I'm happy to jump to questions. Yeah.
No dramas. Krista, you referred to Addis as the canary in the coal mine for issues emerging on the street. Have you got any examples of calls relating to emerging drugs of concern, and how does Addis respond to those at the moment?
I'd really love to hear from Alana on this one, and from anyone else who might be in our webinar session at the moment. If you are a frontline worker, and you'd like to be unmuted, please let us know in the chat. Alana, maybe you can get us started.
Yeah, definitely. I think, speaking from Addis, we definitely get calls from clients, but also professionals, sort of asking, what is this drug? We've not heard about it before. Can you provide us some information? And as you've highlighted, Krista, in your presentation, sometimes we aren't necessarily across new, even street names, and we sort of get a little bit not caught off guard, but I suppose we're transparent and going, I haven't heard that before. Let's talk about that in more depth. Give us some more context, and maybe we can actually identify the drug through this without remembering the street name. But I definitely think it speaks to an area where having a database, so then because we are essentially sometimes the first line responders. So if we can have a database where we are able to upskill and be really across everything, because it is a changing landscape, and it can be hard to always just be one step ahead. Sometimes the callers are one step ahead of us. So we want to be one step ahead if we can.
The next question I had was approximately what proportion of calls are from families and friends? That's always a great question, because often it is families and friends who are worried about somebody else's substance use. And I guess a follow-on question to that is, what type of gaps exist in resources for families?
For Addis here in New South Wales, I think from memory, the proportion of families and concerned other calls that we receive is about 43%, so almost half. It's quite a lot. How Addis could be better resourced to respond to the needs of family and also concerned others, I suppose it goes back to training. Often with those type of calls, it can be difficult not to get swept up in the person that they are concerned about, and being mindful that the caller is the concerned other. And, I guess sitting with that, sitting with the concerns that the caller has, and providing appropriate resources and referrals to them. Yeah, that probably would be my feedback, because we do get quite a lot. Yeah.
Follow-on question then, how could Addis be better resourced to respond to the needs of families?
I think in terms of resourcing, it would be around upskilling in how to work with concerned others and families on the phone. So clinical skills around that, having those types of conversations, knowing where resources are as well. For example, on Your Room, there's information on how to talk to say a young person, so we know where that is to give to a parent if we're getting a parent call. Yeah, that would be my feedback.
Okay.
How do you curate that, Alana? Who curates those lists?
In terms of the resources?
Yeah.
So we have a database where we can filter through resources for families, so whether it's a counselling service or whatnot, but then it's also just our own knowledge of what websites are out there that are available to then pass on to the caller. And I'm sure there's many more that we also don't know about. And we share that amongst the team.
And so then this is another question from somebody, thank you, anonymous attendee, who said, thanks for a great talk. How do we translate findings into clinical education and practice? Probably more a question for you, Krista.
So when NCRED, I guess it is a question for us in terms of this particular study, but I think it's also a great question sector wide around how we work together to achieve best practice for our clients. So one of the things that NCRED did initially was a clinical research priority setting study. So basically having the sector inform what we looked at more closely. So we already had a mandate from the government to look at methamphetamines and emerging drugs, but really just drilling down into what the sector needed within those much broader themes. And then I think the responsibility of then ensuring that those research results get communicated and translated in a way that's palatable for your end consumers. So for example, it'd be interesting, I guess, Alana, or anyone on the call really, to discuss where that could go in terms of translational products. So NCRED has committed in the sense of this study to putting out some products that address those training needs. But that's just one study and one cross-sectional moment in time. But I think more broadly too is understanding what someone on an AOD telephone helpline would be most likely able to access in terms of the limited time to maybe consume those kind of results, and what kind of modalities would be most suitable for that context would be interesting to explore further too. So is it the 3-minute research synopses, the video abstract series? Is it the full academic papers being distributed as relevant? Is there cataloging, or there's kind of a lot of questions around what that might look like, I think.
I think just to further to that point, in my opinion, I suppose having different platforms to communicate different information would probably be best. Some people will prefer to spend more time to read a journal article, whereas others may be time limited and would prefer a 3-minute quick video explaining something. I suppose that then also echoes to staff members and their different types of learning. Some people might be more visual, so a 3-minute video will sort of sit with them better, as opposed to maybe reading a journal article, then that might then sit with them better. Sort of saying do both. But yeah.
Which someone did put in the chat or in the questions, they're asking, did the training needs differ across the country? For example, different needs identified in various states, but not others. So we did set out in the original methods for the research, we did set out to do a lot of those more nuanced analyses, but unfortunately, because the sample is so small, 110 total workers, and then splitting that into half of that, there just is too much risk of identification. So we didn't do those more nuanced analyses to protect our participants.
Okay. Well, following on from the different needs of the different states, what about the different needs of culturally and linguistically diverse people, as opposed to the needs of those that are Anglo-Saxon, English, Australian background?
It's quite an interesting one. I think we definitely get callers from different culturally and epileptic backgrounds. I think we need to be quite mindful of sensitivity around that and navigating that on the phone. I guess sometimes it may come down to sort of, it could come down to language barriers on the phone, and, you know, being mindful that we couldn't add an interpreter, but also how we are communicating on the phone to that caller is very important. Also, I guess being mindful of like cultural barriers, in the sense of maybe stigmatizing, or, you know, I don't want to be referred to a particular program, for example, in a community, because then I might be recognized. So we need to be keeping that stuff in mind. And I think some further training on that could also be very, very helpful, particularly if that demographic is using our service as a first point of contact.
Or perhaps even as an only point of contact if there's a fear of being identified in a smaller community.
Yes, definitely. Most definitely. Yep.
Yes, I think, sorry, go on, Krista.
I feel like that's, you know, and I don't know if you recall, Chris, at a Daria that we held last year, with regards to nitrous, for example, and the high demographic of use amongst students that were culturally and linguistically diverse, and really sort of breaching those gaps in the sense of being able to deliver information to smaller pockets within the community that require the information. In the case of nitrous and some of the clinical responses last year, required that information quite urgently in the sense of the emerging harms. So I guess, you know, it's really, again, it comes down to that idea of some of these smaller communities in smaller sub-communities, or really using the telephone helpline services as a real frontline access point and being able to be responsive. Do you offer, you touched on interpreter services, sorry. Do you offer that routinely?
Yes, we do. Yep. We can most definitely offer to have an interpreter on the phone if it's required. Then a further note on that is sometimes callers may prefer not to, in case they then,
again, the,
you know, talking. Yeah. So I guess that then poses another barrier. So then you're trying to then communicate very clearly and slowly to the caller.
Not necessarily being able to use all the resources that are available to you.
Yeah. So then I guess you are slightly restricted then if they're opting not to have the interpreter, which is at their discretion.
Libby's just put in the chat here as well, just looping back to a source of info about new trends or emerging concerns. So Libby's put in the chat that she would recommend the NUA peer line as being an excellent source of info, both for professionals and clients. And I think that's really good feedback, because that is a really good resource there.
Thank you. Thank you, Libby, for that. I was just going to add as well, the nitrous clients that you talked about, I got a few that I've seen previously. I think there's quite a lot of shame around their use, and I imagine, there's a high proportion of students from Han Chinese background, and so and they've come to Australia to study and learn and whatever else, and this is unfortunately what's they've discovered this sort of subculture, so to speak. And so I can't help but think that there may be a way for this to kind of, I don't know, break down, help with those barriers, because I've actually found it can prohibit their treatment and management and so forth, because they don't want to talk about it. They're shut down, and so I wonder how we can address that as an issue. but nonetheless, it's probably a bit of a big thing to try and take on. So thank you, Libby, for that question. I've got to work my way through. We've talked about that. And somebody else said, thank you for presentation. Looking forward to attending more. Something across the countries. I think we've covered that. This was another question from another anonymous attendee. Are there any specific resources available for people whose needs aren't met by current standard treatment options, particularly for women and primary carers, etc., who use drugs?
I wonder if this question is sort of coming back to the idea of an AOD telephone helpline being a source of anonymity for accessing information, or
I wonder if they're not asking maybe sometimes. So in a public health system, you will sometimes be a bit limited to doing what is absolutely mainstream and, the only, what is got backed by large meta-analyses and so forth. And then there are smaller private practitioners who may practice some things that are, not rogue, but perhaps not as commonly done. So I guess an example would be utilizing something like baclofen for alcohol use disorder, utilizing stimulants for methamphetamine use in this example perhaps might be what they're personally. I think that's where is that where
right.
I could be wrong.
Right.
If that person wants to follow up that comment
That
or
question.
question.
Yeah, I was reading it as I don't want to go into mainstream services and divulge my alcohol or other drug use
that's
in terms of losing custody or risking something with my
that's
my
probably
family
a fair.
situation.
That's probably more correct, I would say.
In which case, I wonder if the alcohol and other drug helplines provide sort of that another like anonymous resource whereby people can access reliable evidence-based information. And I guess, Alana, that goes to the question of how much of the work that's done in your services, if there is a lot of work done on counseling, brief interventions, rather than referring on, actually being a source of intervention at the coalface.
Oh, most definitely. I think there is a lot of capacity, and it's done quite frequently, to have those sort of counselling based brief intervention psychoeducation calls prior to even offering or getting to that point of providing referral options. Some callers they would also just tell you they don't want referrals, they just want to talk about this presenting problem, and that's why they've called today. So there's a lot of scope and a lot of capacity to just sit with that concern. Yeah, definitely.
Okay, I think we've worked our way through all the questions. Thank you to everybody who provided questions. It's lovely to have a robust discussion about these things. So in the chat, you'll see as well that if you want anything in particular in future sessions, send your suggestions through to ncred@unsw.edu.au, and ncred is 2 C's. I should have pointed that out as well. NC-CRED, so to speak. Krista and Alana, did you have anything else you wanted to add before we wrap up?
Not me personally.
Thanks so much for everybody who attended. Yeah. And keep an eye out for the van and the publication.
Fantastic. All right. Well, thank you all. And if there's nothing else, we'll catch up with you next month. And I believe next month we will be having Dr. Thomas Liu, who's a GP reg addiction. Not sure whether he's training or a specialist now. He can tell us next time. But he did a recent review on the discontinuation of opioid treatment, which is a really interesting aspect of treatment about, what are the ways and that people can come off OTP, whether they should come off OTP and how that looks, and safe ways to do that. And so it can be an especially unsafe time for people, or risky period. I shouldn't say unsafe, but risky time. So I think that'll be an interesting presentation. Somebody's just asked, how do we get copies of the presentation? If you go to ncred.org.au, we'll post them up there. And if there's nothing else, then look forward to catching you all next month. Thanks, everyone.